So hi everyone. Today's session on the approaches to diseases as we're going through the residency series is on the approach to red eye. So red eye is one condition where you can see the patient coming to you with a red eye as and when you're practicing as a general physician or you're practicing in a hospital, in a ward, a patient develops a new complaint of red eye. So if a patient comes to you in your clinic and you say that, okay, you just cannot refer every red eye to an ophthalmologist, right? So just suppose if it was just some irritation that is happening or just a allergic conjunctivitis that is happening, you might want to treat it then and there, and even you would want to not let the patient be referred for a minor reason. So that is one reason why you should know about red eye. At the same time, you should also know when it is a sinister complication. You should also know when to tell the patient to go on an urgent basis, on an emergent basis, and visit the ophthalmologist. So in that particular scenario, not just as a specialist, for example, rheumatologist or a nephrologist or any particular person in a ward, a patient develops a red eye, you should know that is one. But also as a general physician, this is a very important topic to know of, and at least the basics you should know. So we'll be going through the main things only. We're going to go obviously very superficially. We're not going to get into any sort of detailed ophthalmology. We're going to just see majority of what a general medicine resident should know. So, what is red eye? Red eye is basically resulting from the dilatation of blood vessels in the anterior portion of the eye, right? So, either it's the hyperemia of the conjunctival or the episcleral vessels. You obviously know what the conjunctiva or the episclera mean. We'll get into the details. I'll show you the picture of the eye and the anatomy as well. But just it's the superficial part of the eye. So, there, if there is blood vessel dilatation, hyperemia, either due to primary pathology at that particular site or due to any other secondary pathology, that is what is leading to red eye. So these are the main causes. So usually what I do is I get through the approach and then I discuss the causes. But because this is a topic where you should know the basics, you should know the fundamentals before the detailed approach, etc. At least the main causes in the order of urgency is what I have told. So chemical injury obviously will come at the highest because it is something that should be treated as on an emergent basis. Then comes angle closure glaucoma, where the patient has significant pain, etc. Ocular foreign body, something that is emergent, abrasion, uveitis, conjunctivitis, and then we go to the lesser dangerous complications like something like a subconjunctival hemorrhage, where it's just conservative management. So once you have a patient who has red eye, he comes to you with moderate to severe pain, then you should ask certain questions, then look for certain differentials, and then decide whether or not to give an emergency ophthal referral. So this is an overview. Again, we'll go through the chapter as we go through. You'll understand why each of these needs an emergent or an urgent referral. But this is something that you should remember at the outset itself. That is something like an angle closure glaucoma, hypopion, hyphema, severe scleritis is something that is urgently that is to be referred, and also bacterial infectious keratitis. All of these are basic conditions that have an ophthalmological referral at the earliest. So then, when a patient comes to you, you would not know the diagnosis, right? So you would just have an information about some signs and symptoms, and these are certain red flag signs that, as a physician or a person who is looking at the red eye but not an ophthalmologist should know, to know when to refer to an ophthalmologist. So obviously decreased vision is something that you would immediately refer. Deep pain, deep boring pain, as we say, something like in scleritis, acute angle closure glaucoma, all of these conditions, then you will refer immediately. Photophobia, again another something that can be a severe conjunctivitis or a uveitis. Unequal pupil or abnormal pupil reactions may even be a possible neuritis manifestation. Then there are injuries, whether it be high velocity physical injury or chemical injury, contact lens use, again because of severe, sinister conjunctivitis that can happen here, neonatal conjunctivitis, all of these will be referred to an ophthalmologist. Again, these are more or less the same things that you can, kind of pause and go through as well. So these are other medicinal complications that you should also know. Hydrocephalus, cerebral aneurysm, all of these will also kind of present in the form of ocular manifestations that you should not miss. Something like diplopia, all of that, you know that you should not miss. Then once they are excluded, then is the scenario where you as a medicine person can kind of slowly take a history, examine the patient, kind of zero in on the differentials and take a decision on management. So we're not going to discuss in detail the management of these particular conditions. We'll just touch upon it, but we'll mostly see when it is not sinister, what are the things that you should look for. So before the red flag signs, you might kind of ask these as a part of red flag signs and also as a history thing, right? So visual loss, it's a red flag sign, and you can directly refer, or you can kind of keep these differentials in mind that maybe this patient might have all these. It can be anterior uveitis, infectious keratitis, severe scleritis, angle closure glaucoma, all of these. If the patient has halos, if the patient has headache, it can be an angle closure glaucoma. If the patient is not having a visual loss, it may be a uveitis also. So what I'm trying to say is, it's not like a patient having no visual loss, it cannot later lead to a uveitis or a scleritis. That also is important. And also diplopia, as I told you, whenever there is diplopia, then you should think of some orbital pathology that is there. Also remember that not always that there is pain. For example, in neurotrophic keratopathy, where there's absent or lost sensation, the patient may not complain of ocular pain even having a severe pathology. So now we come to pain, where we see if it is painless, it may just be a subconjunctival hemorrhage where we treat it conservatively. But if there is mild pain, then there can be either episcleritis, corneal involvement, or conjunctivitis, or even adnexal involvement as well. If there is moderate pain, then we look at severe conjunctivitis, we look at corneal trauma, infectious keratitis, all of these. And also, as I told you, orbital cellulitis. In these conditions, always remember to look for diplopia possibility. Then we come to discharge. So discharge, you also have to try to characterize the type of discharge. This is again something that we usually do at a baseline level itself. Is it purulent, is it hyperpurulent, or is it watery? If it is just watery, it is most likely not a sinister complication. It's just either allergic or viral. If it is hyperpurulent, the classic differential is your gonococcal conjunctivitis. This is, we've been reading through our MBBS days as well. This is basic ophthalmology. If it is hyperpurulent, then possible gonococcal conjunctivitis is a possibility, and other purulent, just mucopurulent discharge would basically mean your normal bacterial conjunctivitis, like your chlamydial conjunctivitis, etc. Then you have a look at if it is unilateral or bilateral. This can give a lot of clues. Acute painful red eye conditions often present unilaterally, something like corneal infections, angle closure glaucoma, scleritis, all of these usually present unilaterally. And then based on that, you can also kind of further examine. For example, if it is unilateral, depending on if there is fluorescein staining. If there is fluorescein staining, that basically means there is corneal involvement, that is keratitis is there. If there is no fluorescein staining, then you will go for other possible differentials like angle closure glaucoma, uveitis, etc. If there is pain, then you kind of have to think about scleritis a lot more. It is bilateral, it is more, again, not very severe, not very sinister complications like your allergic conjunctivitis, infectious conjunctivitis, mostly something like a viral conjunctivitis, and also just sicca or dry eye. This is how your unilateral versus bilateral can help you. So again, kind of showing unilateral painful, it's usually something like a scleritis, something like episcleritis, foreign body. Obviously, foreign body will most likely not be bilateral. Then your adnexal involvement, like your orbital cellulitis, chalazion, all of these also usually present as unilateral painful red eye. If it is painless and unilateral, subconjunctival hemorrhage is the most important thing. And if it is bilateral, then sicca if it is painful, or if it is painless, then again these mild conjunctivitis, that is viral and allergic conjunctivitis. So here I just want you to remember the specific additional features and your main what is seen and what is not seen. For example, severe pain is usually not seen in your conjunctivitis and your dry eye, that is sicca. Even subconjunctival hemorrhage, usually subconjunctival hemorrhage will almost be asymptomatic. There'll be no severe pain, irritation, as you can see here. There is nothing of these manifestations, no severe pain, no irritation, no epiphora. Epiphora is basically significant watery discharge that is there. Photophobia, reduced acuity, all of these are not there. Then you have your acute angle closure glaucoma, where there is usually severe pain, photophobia, and epiphora, and reduced visual acuity. Conjunctivitis, again, there is no severe pain. Episcleritis versus scleritis, this is something that we will discuss later upon. Then uveitis usually will present as your severe painful red eye with photophobia and possibly reduced visual acuity. Not always there will be visual acuity, but sometimes there can be. So scleritis we will discuss later. Uveitis is something that you should know, and conjunctivitis versus keratitis also you can kind of look upon. Acute angle glaucoma is something of a red flag sign. Once you have that particular possibility, you will directly refer to the ophthalmologist. So again, here mainly you can focus only on the cardinal feature. So if it is an adnexal involvement, that is lids or lashes, etc. are involved. If it is tender, most likely it's a stye or a hordeolium. If it is non-tender, if it's a chalazion, and if it is chronic, then usually it's the inflammation of the lid, that is blepharitis. Conjunctivitis, again, you will kind of have that significant discharge as your main complaint. There will not be much pain, it will be significant discharge. If it is all day, it is usually bacterial. If it is minimal discharge, only watery serous discharge, then it is viral. And if there is significant itching, it is allergic. Episcleritis, as I told you, very, very minimal pain, almost no pain, or it may just be a dull ache. And subconjunctival hemorrhage, there'll be no major complaints at all. Abrasion, main thing that you should remember is your fluorescein staining that we will see ahead. Contact lens history should be taken. Foreign body history, you kind of get a background from. Then bacterial keratitis, white spot on cornea will stain fluorescein. Always remember, whenever there is fluorescein staining mentioned, it is something related to the keratitis, whether it be cornea, whether it be corneal abrasion or keratitis. Even viral keratitis will also usually stain with fluorescein. Then we come to the anterior chamber, that is the iris involvement. It can either be iritis, hyphema, or hypopyon. These will be, kind of, you can see them on the slit lamp. If on the slit lamp examination, if there is a flare, that is, there is a significant light that is being distracted when you see it on the slit lamp, that is possibly a uveitis. If there is ciliary flush, we'll see the image ahead. So ciliary flush basically means a increased blood vessels that are there around the eyelid, if you around the dark part of the eye, that is the iris. So ciliary flush, again, sign of your iritis. And hyphema as well as hypopyon, both you will see levels is something like pus formation, pus collection that you see on the slit lamp. If it is red, then it is hyphema, that is your blood is spurting out. And if it is WBCs, then it is hypopyon. Angle closure glaucoma, again, here you will see fixed mid dilated pupil. And once you see a fixed mid dilated pupil, directly you can refer to the ophthalmologist. So now these were the history that we saw. Now we come to the examination. In examination, firstly, you would obviously do the Snellen's chart, see if there is any decreased visual acuity, and then see where the redness is. So this is one clue, that where the injection is basically your conjunctival injection, or where the redness is in the eye. So depending on where the redness is, if it is diffuse superficial hyperemia, then you can consider conjunctivitis and dry eye, or keratitis, that is corneal inflammation. As simple as that. That is very superficially the changes are happening either in the conjunctiva, the cornea, or there is generalized dryness. If it is localized, and if it is superficial, so if, as you can see here, you can easily differentiate whether the redness is superficial or deep. If it is deep, it will not be clear cut red in color, it will be somewhat for brownish in color. So this is over. This is keratitis, conjunctivitis, or Sika, right? So if it is localized and if it is superficial, it is usually subconjunctival hemorrhage. That is the main thing that you should remember. And if it is diffuse and deep, so here you can see it is diffuse and also deep. Deep in the sense that there is again a brownish hue that is there. So here mainly you remember scleritis, and also there is a possibility of your sinister complication, that is angle closure glaucoma. If there is severe keratitis, so keratitis we discussed here, right? If there is severe keratitis, that can also look as a deep red in color. If it is circumcorneal, sir, what does circumcorneal mean? So as you can see here, is something like around, as I told you, ciliary flush. So this is what I was talking about, ciliary flush, and this is your main differential of your acute red eye, which you as a medicine person, as a physician, you should know, and that is uveitis. So these are your main differentials which you can kind of zero upon based on the collection, or based on the depth as well as the location of the redness that is there. Then further examining the patient, you will see where the vesicles and the rashes are, whether it's the tip of the nose that is involved or the lateral aspect of the nose that is involved. So this is something that you might have read in your MBBS. If you remember, it is called the Hutchinson's signs, right? So Hutchinson's sign is basically related to the nasociliary nerve. So nasociliary nerve, first leading into the eye, the nasociliary nerves basically first kind of supply to the lateral part of the nose and the tip of the nose before they go into the inner part of the eye. So if there is involvement of this nasociliary nerve by herpes zoster virus, you can get a clue that there will be lesions, or there will be complaints on the lateral aspect of the nose or on the tip of the nose before the eye is involved. So if the nose is involved, you get a clue that the eyes are most likely to be involved. If not now, slowly that manifestation will come about. If there is periorbital swelling, it's usually cellulitis, either preseptal cellulitis, which is slightly less serious, where it is more just the soft tissue around the orbit that is involved, or it can just be orbital cellulitis, which is more of a serious complication. Periocular eczema or inflammation, this is also something that you should remember. If there is periocular eczema or inflammation, it can be suggestive of an allergic eye disease, something like an allergic conjunctivitis, something like a contact dermatitis. All of these can be kind of inferred from if there is periocular eczema or inflammation. Then you examine the cornea. So when you examine the cornea, you basically shine a light such as a pen torch or something, and then you look straight ahead. And if there is a white infiltrate at the superior temporal limbus, right? So this is the white infiltrate that I'm talking about. If there is some white infiltrate like thing at the superior temporal limbus, and there is marked conjunctival congestion also, as you can see here, this is possibly a patient of keratitis. So these are good clues that, again, on simple superficial examination, you don't need to do a slit lamp, you don't need to do some hi-fi ophthalmological investigation. Just simply taking a pen torch, looking and trying to find out, right? So you don't need to kind of have a complex ophthalmological information. Just basic clues, if you can pick up, you imagine how useful it will be for the patient, right? So just a simple, kind of finding, like finding this white infiltrate at the superior temporal limbus, can possibly get you to a diagnosis of keratitis. So infectious keratitis, if it is really opaque, if it is really white, very opaque white in color, then it is another clue for infectious keratitis. Then you examine the pupils. This is also something we obviously see. You see the size of the pupils, if it is fixed, if it is reacting, how, if it is direct reaction, the consensual reaction, all of this you will see. And it should be checked when the vision is affected, especially checked when the vision is affected or there is a possible orbital pathology. Non-reactive pupil, you should always remember the differentials of non-reactive pupil, because again, this is sometimes what we see is when we see a non-reactive pupil, we almost always think of a nerve pathology, but it's not like that. One thing I already told you, when there is a mid-dilated tonic fixed pupil, one thing always you should remember is your angle closure glaucoma, and immediately refer to the patient. Sometimes what happens in your anterior uveitis, especially when there are complications, synetia are formed. Synetia are basically the iris being kind of attached to the cornea. We'll see ahead what synetia means. When the iris is attached to the cornea, then also there is difficulty in pupil dilation. So when there's difficulty in pupil dilation, here what happens is a non-dilating. So it is fixed, but it is more due to the synetia formation. So here there is a small non-dilated pupil. But in case of, so this is about uveitis, right? Uveitis with complication, that is synetia formation. Here it will be a non-dilated pupil, but it will be a small non-dilating pupil. But in case of your angle closure glaucoma, here also it will be non-dilated. It will be kind of non-reactive. That is your mid-dilated pupil, and it is called a tonic mid-dilated pupil. What do you mean by mid-dilated? It will not be small. It will be kind of a middle between a pupil which might be in your dark versus in your complete light. It will be mid-dilated. Then when you palpate the eyeball, this is one kind of maneuver where you can see, depending on the palpation, you can see how hard the eyeball is, and depending on that, although it's quite subjective, but you can also kind of get you can get a measure of the tenderness, you can get a measure of the hardness. All of these will also help you for a possible glaucoma inference that is there. So this is something what is called digital tonometry. You know what is tonometry, right? Tonometry is the measurement of your intraocular pressure. So whenever you're doing a tonometry, you're using your fingers, it is digital tonometry, and here you can get an idea of your angle closure glaucoma. Then hyphema and hypopyon that we discussed as RBC level or WBC level that we see. So if there is a white layer cells of when there is a layer of white cells in the anterior chamber, then we call it as hypopyon. If there is a layer of red cells in the anterior chamber, is hyphema. So both of these should be immediately referred to an ophthalmologist. Usually hypopyon occurs in your severe infectious keratitis or endophthalmitis, etc., which are to be immediately referred. Hyphema is usually seen in traumatic complications. Whenever there is significant trauma to the globe, then we see hyphema. Also, it might have associated significant complications like retinal detachment, all of that. So immediately refer to an ophthalmologist. So these are again summarizing it. Visual acuity immediately should be seen using your Snellen charts at least. Then you should see for the pupils, as we discussed. You should look for the size of the pupil, the symmetry of the pupil, reaction of the pupil, all of that. And the external eye for any possible external ocular adnexal complications that can be found out. Then you should look for the conjunctiva. Conjunctiva also, I told you about. You can look through the conjunctiva, this depending on the depth of the redness, the basically if it is superficial or deep, and also the location of the redness. You can kind of zero in on some differentials. Then about the cornea, again, cornea, you will look for possible foreign bodies. You will look for possible signs of keratitis. Here you will look for corneal light reflections also, which I had told you. And very importantly, fluorescein dye. Fluorescein dye is a very classic sign for corneal involvement. It is seen for any disruption of the corneal epithelium. What do I mean by this? That when you stain fluorescein, if there is no defect, then fluorescein will not stay in that particular area. If there is no corneal defect, fluorescein will not stay. But if you, after washing out, if you see that fluorescein has got stuck somewhere, then that is one sign for your corneal defect. Anterior chamber, we mainly talked about hyphema and hypopyon, and these are basically complications associated with your uveitis. Intraocular pressure is not something that I would advise you to go very deep into. Once you have any particular sign or any particular signal that this can be a glaucoma, directly refer to an ophthalmologist. Fundus examination is something that you would know as in when you see patients of your hypertension, etc. And also you can have this as a add-on that you may try to look for retinitis also in this particular area. So this anatomy we have already discussed as in when we have been going through till now. So conjunctiva, palpebral conjunctiva, bulbar conjunctiva are your two main conjunctivas, and also there is limbal conjunctiva, which is basically at the border. So this is mainly looking at your various adnexal compartments of the eye, where you have various lacrimal gland components as well as your various lid components. We're not going to get into the detail, but this is something that is important. This is basic, but a lot of times when we go through a lot of medicine, we kind of end up forgetting our basic ophthalmology. So just remember, iris is basically your black part of the eye, the center of which is your pupil. Then you have your conjunctiva, which is your significant outer part of the eye. As I told you, this is your okay. Here conjunctiva is not just a second. So conjunctiva is not labeled in that particular image. So yeah, conjunctiva is something that we discuss separately, right? So conjunctiva is basically the outermost layer of your eye. So conjunctiva can be divided into palpebral, limbal, as well as your bulbar conjunctiva. So apart from all these, we can also divide the eye into anterior and posterior segment, and this difference is at the level of the lens or the ciliary body. So everything in front of the ciliary body is your anterior segment, behind the ciliary body is your posterior segment. So coming to ocular adnexa, the two main things that you should remember here are what is the name of the condition and what does it mean. So hordeolum or stye is basically the follicles that are there. The follicles or the oil glands that are there, they, when they get obstructed, they produce this swelling, which is basically called hordeolum or stye. It basically just looks like a pimple that is there, and it develops near the skin surface, and that is adjacent to the cilia. So it's not really, it may be infected, superimposed infection can occur, or they may just cause some redness and discomfort. Then there is chalazion. So here these meibomian glands will drain through a small structure opening at the posterior edge of the lid margin. So whenever this opening, the meibomian gland orifice is there, when this gets obstructed, then again these glands will enlarge, they'll get tender red, and also this whole swelling area is what is called chalazion. So then you have this blepharitis. Blepharitis is basically a chronic inflammation involving your eyelashes and the surrounding eyelid. This is sometimes associated with your dry eye, etc., but it's predominantly just a harmless inflammation unless it gets superimposed infection there is there. Then here ocular adnexal is mainly, there are two main complications that are involved here. One is preseptal cellulitis and there is cellulitis. If it is anterior to the orbital septum, so orbital septum is basically your one of the barriers in your eyelid, right? If it is just anterior to the orbital septum, presenting as edema, erythema, then it is called preseptal cellulitis. It's not majorly severe, but if it is involving the entire eyelid, including the posterior portion of that orbital septum, then you call it as complete orbital cellulitis. Dacrocystitis, no need to tell you, it's basically the inflammation of your lacrimal gland that is there. Then you have your ocular surface causes of your red eye. The obvious one is your conjunctivitis. If it is hyperpurulent, gonococcal. If it is just purulent, bacterial. If it is just watery, then viral. So this is your purulent discharge that is there involving your bacterial conjunctivitis. In fact, this looks like hyperpurulent, so this might even be gonococcal conjunctivitis as well. Then if it is just, just redness is there, watering is there, and there is associated irritation, etc., itching, etc., is there. And also very importantly, remember, if there is an associated preauricular palpable lymph node, then these are what are signs for your viral conjunctivitis. So viral conjunctivitis is essentially self-limiting only. You don't need any specific treatment, but again, it's highly contagious, so you should definitely stay at home when you have this. Then you have allergic conjunctivitis, predominantly severe to your viral conjunctivitis, but here the redness is slightly less, itching is more prominent complaint here, almost no pain is there, and what we define it is your white stringy mucus. So if this is given in your exam, if at all it's given in your MCQ, then this is a classic clue that it is a allergic conjunctivitis, and obviously the treatment will be removing of your offending agent. And this is something that you should never miss. This is very, very common in your ward patients also, especially if somebody is on aspirin, if somebody is on some anticoagulation, even high doses of vitamin E. All of these will possibly cause this particular complication or just a condition that is your subconjunctival hemorrhage. So what do you do here? You basically manage conservatively only. There is no therapy, just reassurance, and usually clear in 2 to 3 weeks. Then you have pingicula and pterygium. So this is again something that was a very common MCQ in our NEET PG days. So here pingicula is whenever there is confining to the conjunctival tissue. So this is basically increased vascularity of the tissue. Some sort of inflammation is happening. If it is confined to the conjunctiva, then you call it as pingicula. But if it is going into the cornea, then we call it as pterygium. So pingicula versus pterygium, the main difference is your extension. If it is extending into the cornea, then you will call it as pterygium. If it is involving only the conjunctiva, then it will be called as pingicula. The only difference, another difference with respect to not difference as such, your mainly treatment modalities are use of artificial tears and your vasoconstrictor agents. And these vasoconstrictor use is more usually used for your pterygium. For if it's just a pingicula, you say that you use artificial tears, and if needed, if it will resolve on its own, but if needed, it can always be removed as a minor surgical procedure as well. So this is something that I just wanted to kind of for you to revise, because this is something that we usually forget as we go through our as we complete MBBS. So here this is basically your lens. I just want you to go through with me what is 1 2 3, so that you kind of guess, and then I write it down for you. So one, you should obviously know that it is the lens. Two is your ciliary zonule. So these are what are holding the lens, right? Then three is your posterior chamber. So this is something that is, this is the iris, right? I'll use blue here. So this is the iris. This is the iris, and this is basically posterior to the iris, and your ciliary body is your posterior chamber. Anterior to it is your anterior chamber. So number 3 is your posterior chamber, while number 4 is your anterior chamber that is there. Then you have number 5, right? So number 5 is basically your pathway. So number 5 is how the aqueous humor flows. Aqueous humor basically is formed by the ciliary body, by this particular area, and then it goes like this. It goes like this as the arrow is showing. So as you can see, this purple arrow, I'm not going to kind of disturb the colors here. So purple arrow, as you can see, this is how the aqueous humor flows. 6 is the pupil, that basically the area between the iris, and then yeah, so 7. So 7, once we come, this is the corneoscleral compartment. This is involving both the cornea as well as the sclera. For example, this whole anterior portion, this is the cornea. Then we also have 9. So 9 is basically your, again, a canal from where the aqueous humor will flow. So here the aqueous humor has come from the posterior chamber to the anterior chamber. From there it should go, right? So there it has two flows. One is the trabecular flow and other is the uveosacral flow. And this 9 is the trabecular area from which the aqueous humor will flow out. Then you have the corneal limbus, which is basically the junction at the end of the cornea and where the sclera will start. And then you have 11, which is basically your sclera. So cornea basically ends up into the sclera posteriorly, and at the junction is the limbus. Then 12 is your outermost part of the eye, that is your conjunctiva. As you can see here, this is the outermost part of the eye, and this is not basically essentially a continuation of anything. This is basically the outermost part of the eye. Then you have the most important part, 13, that is the uveal apparatus. So uvea is your most important part, and this has mainly two things: the iris and the ciliary body. Iris, that is something that we had discussed in the beginning. This is the iris, and this whole thing is your ciliary body. So once we see that, then we will see what the main components or main pathologies of your anterior segment, because this is the most important area. So these are basically your various findings that you see in your corneal involvement, right? So this is something that I told you before, that is your fluorescein staining. So whenever somebody says about fluorescein staining, directly go to corneal involvement, either it be a keratitis or any abrasion, as you see here. So this is a corneal abrasion where you're seeing an irregular corneal reflex. So this is your irregular corneal reflex, where there you can clearly see, right? So this reflex is very irregular. It's like, it's not your straight circle, right? So this would be a regular corneal reflex, but when I remove this, you can see this is quite an irregular corneal reflex, and it's almost looking a vague, weirdish opacity that is there. So here what they did is they took this strip, they added fluorescein dye into it, and once fluorescein dye was added, this stained certain areas, and those are the areas where there's a defect in the corneal epithelium. So that is the main thing that we do when we use this fluorescein dye. The defects in the corneal epithelium are stained. So abrasion basically presents with redness, that is what we've been discussing, that is red eye, tearing, photophobia, pain can be there, cannot be there, foreign body sensation very commonly there, and rarely blurring vision can be there. So mainly, again, basically you have to prevent infection, and you should give your cycloplegics as your, to prevent any of your ciliary muscle spasm, and also you have to give your analgesics for pain relief. Then you have something that is, again, immediate referral is needed to your emergency medicine physician, or more importantly an emergency ophthalmologist, and these are your significant chemical burn. So it can be physical burn or your chemical burn that can happen, but whenever there is an associated acid or an alkali, especially alkali, it is a very severe chemical burn. So here what is happening is there is severe pain, there is severe discharge, and it almost looks like a melting eye that is there. So that is what is a chemical burn, and you can kind of irrigate the eye at your center itself. 20 minutes of immediate irrigation with the nearest source of water possible can be vision saving for the patient. But if at all you are kind of afraid about the possible differentials, you're not sure of the differences, if it's just looking like a possible chemical burn, you can directly refer to an emergent ophthalmologist. Referral as well can be given. So next you have again something that is involving your cornea. Significant corneal redness, hyperemia is there, possibly purulent discharge that will be there, and here it is associated with decreased vision, that is bacterial keratitis. So here again you will see a corneal opacity. So corneal opacity again may be irregular, may be regular, depending on the progression, depending on the severity, but corneal opacity with significant redness, that is your bacterial keratitis. So this is again important clue, right? So what are these? These are small vesicles that are forming, and this is a dendritic sort of opacity that is there, and this is your viral keratitis. The most important thing that you should remember is that it presents unilaterally. One, epithelial dendrites are there too, and also most important, do not give topical steroids. So there are a lot of conjunctivitis, especially allergic etc., you will give, but a lot of times allergic conjunctivitis is a very close differential to your viral conjunctivitis. So better to be sure that it is not viral, because there are multiple reasons because of which topical steroids are contraindicated in your viral keratitis, and also topical anesthetics are also contraindicated. So do not always jump to the conclusion that this looks like an allergic conjunctivitis and end up giving them topical steroids. That is not the way to go, and this is my kind of message from that particular slide. So angle closure glaucoma, again we're not going to discuss into the depths. We've seen how the aqueous humor flows, either the UV sacral outflow or the trabecular outflow. Basic message here is, once you suspect an angle closure glaucoma, that we have seen what are the signs that give us a suspicion, you directly refer. So initial treatment, again, not your work, but this is something that we have been reading through MBBS. You use various agents that basically on your muscarinic as well as your adrenergic pathway, either it be beta blockers like timolol, pilocarpine, clonidine, alpha-2 agonists, acetazolamide, your carbonic anhydrase inhibitors. All of these we know very well. Then you come to a portion which we have discussed in the other parts of our residency series, that is uveitis. So uveitis we have discussed in our series, which is from your organ to disease series. So there you can go and look at a more in-depth review. But even if you just see a red eye, always keep it in mind, especially when there is a ciliary flush. So ciliary flush and irregular pupil, all of these are again indicatives of a possible uveitis that is there. Here it may or may not be fixed, but a lot of times if there is posterior synechiae formation, so again we'll immediately go a bit back to that image, right? So here, what is posterior synechiae and anterior synechiae? So I'll use the blue color here. So this is the iris, right? So this is the iris. If this iris is kind of sticking to the cornea, so this iris has gone here and it is sticking to the cornea, that is what we call as anterior synechiae. But if this is sticking here or here, then we call it as posterior synechiae. So in posterior synechiae, it becomes very difficult to the iris to open and close, dilate and constrict, and that is when there is a fixed pupil that occurs in a complicated uveitis patient. So always remember that there's a patient of uveitis possibly whenever there is a fixed pupil that is there. Then yeah, this is something that we have discussed. Again, going through it again, so a patient has uveitis, patient is referred to you from an ophthalmologist. What are the things that you can rule out? So always remember, the ophthalmologist, if he doesn't have a actual cause for uveitis, he will refer to you asking for a possible systemic illness, uh, kind of association that is there. So that does happen in 40% of the cases. 20 to 30% of acute anterior uveitis will have ankylosing spondylitis, and 30 to 40% of ankylosing spondylitis will have acute anterior uveitis that is there. So the most common systemic illness is your ankylosing spondylitis, and you have to clinically, as well as with examination, as well as possible requirement of radiography, you will screen for angspond. In SPA, it usually kind of presents as your acute alternating additive uveitis, and a lot of times it's asymptomatic as well. In IBD, that is inflammatory bowel disease, psoriatic arthritis, and other spondyloarthropathies, also it presents. But what is to be remembered is in psoriatic arthritis especially, a lot of times it is chronic bilateral posterior uveitis that happens. Sarcoidosis, the second most common systemic disease with uveitis. Here it is called granulomatous uveitis because lots of cells are deposited here. And also here you should always remember that it's not just a uveitis, but sarcoidosis can involve any part of the eye, including a sinister complication that is retinal vasculitis as well. GIA, so GIA, that is your juvenile idiopathic arthritis. Here you should not only remember that it is a chronic uveitis, but a lot of times it is asymptomatic. In your spondyloarthropathy, in your angspond, also many times it's asymptomatic, but in GIA, it is present for a long period of time while being asymptomatic. It is something called as white eye uveitis, that you won't even see redness, but there will be uveitis. There is ongoing inflammation happening inside the eye, and the patient may directly land up in synechiae, secondary cataract, secondary glaucoma, all that may occur without even a red eye. So that is why it is called white eye uveitis, and that is what this is. That is chronic asymptomatic uveitis will occur in your GIA versus your acute asymptomatic uveitis is asymptomatic, or your alternating or additive uveitis that happens in your spondyloarthropathy. So this for you is not required at this stage. You can go through the uveitis part. There we have discussed this a little bit more. That is your other possible differentials in your uveitis. So this is a very beautiful image depending on the anterior versus intermediate versus posterior uveitis. So for example, Behçet and sarcoid are two conditions where there can be any sort of uveitis, either anterior, either intermediate, or your posterior. So what are these anterior intermediate? It depends on which part of the uvea is involved. If it is the ciliary body that is involved, then it is an intermediate uveitis. If it's a posterior part that is involved, that is posterior. And if it is the anterior most part, that is your iris part, then it's your anterior uveitis. Spondyloarthropathy and your GIA are predominantly anterior, although sometimes GIA can cause posterior uveitis. And also another important part is your IBD. IBD also can occur whether it be anterior, intermediate, or your posterior. And your other various complications various syndromes, they usually present as your posterior uveitis. And among all of these, always remember that you should always keep an eye out for infections. Something like syphilis can again present as any of the types of uveitis. Viruses can present either as your anterior or your posterior uveitis, especially your herpes viruses. And your TB is usually posterior more than anterior uveitis. So this is again similar thing. Main thing I wanted to add upon is your pan uveitis, that is all parts of the uvea is involved. And here again, these two differentials stand out, that is your sarcoidosis and Behçet disease. Then finally, there are two other conditions that are something like your differentials for uveitis presenting as your red eye, that is, which is something what we already kind of touched upon, that is episcleritis and scleritis. So episcleritis, usually there is no pain, scleritis there is pain, and also both will have some association with autoimmune diseases, but episcleritis it is significantly lesser, while scleritis it is much more, right? So scleritis, mainly whenever a patient with scleritis comes to you, you should always rule out GPA. GPA, you have to do PR3 titers, that is your autoantibody titers, and also you should always kind of work up for other possible systemic involvement as well. RA usually doesn't present directly as scleritis. For example, Wegener's can or GPA can directly present as scleritis as the first manifestation, while RA, usually late RA manifestation is only, kind of comes in the form of scleritis. So this is a very nice table. So pain usually is only scleritis, conjunctivitis, episcleritis, almost no pain. Causes we have discussed: redness, it is diffuse in your conjunctivitis, while in your episcleritis and your scleritis can just be sectoral and relation to systemic disease, mainly scleritis. So episcleritis, there can be association, but it is much lesser when compared to your scleritis. So this is your main differentiating aspect with respect to episcleritis. Scleritis, main thing is pain, which is in your scleritis only, and your vision loss, blurred vision, photophobia, all of this is usually with respect to scleritis. Physical examination mainly is with respect to the vessels. So in scleritis, the vessels are adherent, right? So for example, when you put epinephrine, 2.5% epinephrine or pilocarpine, there will be vessel response to that particular topical agent. But in scleritis, the vessels are so adherent to the underlying connective tissue that there will be no response to any particular vasoactive agent. That is, these are things that are used to differentiate between a confusing episcleritis versus scleritis. Treatment in episcleritis self-limiting, while scleritis you should use immunosuppression. So overall, depending on whether it is life-threatening or non-life-threatening, you will use immunosuppression or not. If it is vision threatening scleritis, then definitely you will go for systemic immunosuppression. If it is non-vision threatening, you will use predominantly topical immunosuppression. So these are various a little bit of in-depth treatment of your scleritis. The main thing that you should remember is, if it is vision threatening, if it is necrotizing, if it is posterior involvement, then you will go for systemic immunosuppressive therapy. Otherwise, the main thing is your NSAIDs only. So this is with respect to your red eye, right? So next we go to our second portion, that is your approach to urticaria and angioedema. Just give me a two minutes.